Morning, everyone. I'm Misty Davis. I'm the Director of Education and Programs for Florida HFMA. And our next session is going to be an exciting one. We actually have a panel, and it's entitled Bridging the Gap Between Revenue Cycle, Reimbursement, and Finance. Before we get started, I just want to give a couple of quick announcements. First of all, I want to take a minute to thank our session sponsor, MedMetrics. I think most of you know our President-elect, John Levine. He worked with MedMetrics and is probably who you know from that group. Also, as a reminder, if you need CPE credits, you'll need to make sure you have logged in to the meeting with your first and last name and stay on for the duration of the presentation, as well as answer all 3 polling questions to get credit. If you have problems with the polling questions, put a note in the chat box. It's not taking your answers, and we'll get that taken care of. If you've dialed in by phone only, we will not be able to track your attendance, so please log in using the link located in your calendar invitation. Afterwards, you'll receive a post-event survey that will contain links to the recording, feedback survey, and your certificate. Please feel free to add any questions to the chat box throughout. We will answer those at the end. If it's timely, we may even throw them in the middle. But if time does expire, then we'll certainly get your response back to you via email. I'm going to do a quick introduction of our panel. First of all, we've got Candace Abbott. She's our moderator. We have Elisa Burt, Cheryl Boucher, Robert Howie, and Mike Stubbe, and they're going to give a little more introduction to themselves as they go along. So, Candy, take it away.
Hi, good morning, everyone. I'm Candace Abbott, and I just wanted to first, before we move forward with the HFMA education session, I did want to give our expert panelists the opportunity to just give a quick introduction of themselves and tell us where they're from, what organization they're from, and maybe even just tell us what they love most about their job or working in healthcare, just to bring a little bit of an exciting twist to our morning. So Cheryl, do you want to go ahead and kick us off?
Sure. Hi, everyone. I'm Cheryl Boucher. I'm the VP of Revenue Cycle here at Memorial Healthcare System. We're in South Florida. Actually, we were in the stomping grounds of where HFMA was going to have their actual meeting. So I'm missing the day at Margaritaville, but I'm very happy to be with all of you today. What I love about my job is that no day is ever the same. And that can't be said even more so in the past year and a half. Every day I come in and it's a different thing to do. And I love the diversity of Revenue Cycle.
And Elisa?
Good morning. My name is Elisa Burt. I'm the Vice President of Financial Operations for the Broward Health System, which is the other 2/3 of the county from Cheryl. And one of the things that I love most about healthcare is that we get to use business to positively impact the communities that we live
in. Mike?
Good morning, Mike Stubbe. I'm the Assistant Vice President of Managed Care for Orlando Health. Miss seeing all you in person, but that's really one of the biggest parts of my job that I enjoy the most, just the interpersonal interpersonal interactions we have with others in the business, and getting to do business with all of you and others in the industry is always a thrill. So glad to see you logged in here virtually today.
And last but not least, Robert Howie.
Hi, I'm Robert Howie with the University of Miami. Also in Dade County in South Florida, but still residing up here in North Florida in Jacksonville. Happy to see everyone. Definitely sorry that we're not able to have our in-person conference at Margaritaville. So what I like about healthcare, obviously in my field with reimbursement, is dealing with a complex regulatory world, and then being able to communicate that into a sensible in nature, then to affect operations, and how do we report properly? Also, how does it affect us as an institution from a financial perspective? So that's what I enjoy.
Thanks, guys. And, I will echo a lot of what Mike said. I think what excites me the most about coming to work every day is really meeting with people and seeing people. And obviously what I miss most about the conferences is being able to network with all of you. So it's something I've always enjoyed and I miss, but at least we have this. So I'm very happy to Florida HFMA for putting this on for us. As you all can see, we have pulled together a team of expert panelists with a nice variety of disciplines and backgrounds. We have finance, reimbursement, revenue cycle, and managed care represented here. So I do feel like we're going to be able to demonstrate how these teams have successfully bridged the gap between revenue cycle, finance, and reimbursement. They might even be able to share some lessons learned with obviously years of experience accumulated here in this conference. I'd like at some point when we do some of these polling questions, I might ask you guys to be a little bit interactive. I do like to engage the audience. Anybody that knows me, I like to kind of just get everybody involved because I do think how we learn is really depending on each other. More brain power from everybody on this call, I think we could probably rule the world. So, so let's move forward. I think when the five of us got together to really talk about how we either in our organizations where we're currently at now or in prior organizations, how we've bridged the gap between revenue cycle, reimbursement, and finance, there were probably five major areas that we really felt we needed to have to be able to do that. The first area was structure, looking at how we structured those teams. The second area was ownership and controls, kind of keeping each of those departments or cost centers or areas of operations, however you think about that in your organization, keeping controls and kind of having accountability to each other to do that. Most likely in those areas, they probably all report up to a CFO. So you would think that under a CFO's purview, you're going to figure out how to have those areas be accountable to each other to then obviously have successful financial outcomes. We also talked about data and reporting. Obviously, none of us would be anywhere in finance without good data and good reporting. So we need to be able to consider that. Collaboration and technology. So I would say that I'm going to first pose a question to the panelists regarding structure. Have any of you found a successful structure in your organization that you felt brought these teams together to be able to bridge the gap in those areas? I'm going to ask any one of our panelists to jump in and answer that question.
Well, Candy, I'll go first. So this is Mike Stubbe. I've got a little perspective on this that is both reflective of where I'm at today and where my previous organization was. I was at the University of Florida Health System before I came to Orlando Health 5 years ago, and there's a distinct difference in how we're structured. So when I was seeking the opportunity to join Orlando Health, it was actually under the auspices of bringing the managed care department into the revenue cycle leadership. So Michelle Napier, our chief revenue officer, that was her vision for how managed care and revenue cycle could be integrated. And I was a big fan of that concept because I had the opposite at the University of Florida where revenue cycle and managed care were separate. And that created some inefficiencies and some disconnects within our organization structure. So here we've blended the two, and it makes the process of going through day-to-day, week-to-week, month-to-month revenue cycle that much easier for everyone, not just for us in managed care because we have revenue cycle people who we collaborate with, but also it makes their jobs easier because they've got direct access to us in managed care. So we've intentionally designed that in such a way to give ourselves the most efficiency really in dealing with the more difficult side of the industry, which is the payer side. So again, I offer that up as an example of one organization that's integrated it and how we're having some success with it.
Do any of the other panelists have an example or something that they've done in regards to structure in their organization that they feel has maybe a little bit different than Mike's, that has different outcomes?
Yeah, I'd like to pipe in here for a second, if you don't mind. At Broward Health, I thought one of the interesting things, and I'm only with Broward Health a year as well, so I've come from a different environment that had a different structure. I thought one of the unique things that I saw here was that we carved out the denials team from the traditional revenue cycle umbrella and moved it directly under the managed care umbrella, which is not the same umbrella like in Orlando Health. It's actually two separate tracks, although they all fall under the auspices of the CFO. And one of the things that we've seen there, we've really been able to positively impact our first pass denial rate in a way that is effective because we have that firsthand knowledge of denials by payer. They can have those critical conversations with the negotiating team who can then forward that back to the payer and really make some inroads there. So I thought that was a unique and really positive experience that I've had so far at Broward Health.
That sounds interesting. Elisa, do your denials team also work technical denials and clinical denials all together in that team?
They do. We actually structured that team to work both sides of the equation. So we transitioned case managers from each one of our hospitals into that centralized unit, as well as the technical side. So it is truly a full-scale centralized denial unit.
And do they focus on, like, are they payer specific, or do they kind of round robin any payer when they're working those denials?
So I would tell you that they're round robin, although I would tell you that maybe in the future when we're a little bit more seasoned in this space, that maybe we would go and look at payer specific can be even stronger. But as it stands right now, we've been really just more of in a round robin fashion. But I can tell you that, from an indicator perspective and a KPI perspective, identifying controllable versus the uncontrollable in that space, we've definitely seen some positive movement there.
Very interesting. I like that structure. The next area that we were in this, at least for this panel, considering what would be important to do for these teams to be able to bridge that gap between finance, revenue cycle, and reimbursement. We started to look at ownership and controls. I think I'll just give a little bit of my personal experience with this. Before working for the healthcare district of Palm Beach County, I worked at Martin Health for about 17 years. That's in Stewart under Chuck Cleaver. He was my CFO, and he was pretty emphatic about making sure that finance, reimbursement, and revenue cycle all reported up to him, but they were in different departments, and we built KPIs and controls between each other. An example would be, for instance, if you have your reimbursement area actually looking at contractual variances from what you actually expect every month, and you start to see a trend, they would actually work with the revenue cycle team to talk about some of those adjustments that were occurring, and try to trend out those adjustments, and then kind of hold each other accountable for not building out new adjustment codes without talking to your reimbursement person, not just making adjustments based on things that come through, and actually if they identified trends, working with the reimbursement area and vice versa. So that was I wanted to give an example of how we try to bridge that gap, at least between revenue cycle and reimbursement, in regards to an example of looking at and analyzing contractual variances.
Mm-hmm.
Is there any other, anyone else in the panel that can give an example of how your organization has held your teams accountable to manage these financial outcomes between these areas. Obviously, all of these areas have a huge impact on our financials as well. So is there anyone else on the panel who has an example of what you guys have done in your teams?
So this is at Memorial, I kind of call it the three-legged stool. So all of us are important to make sure that stool stays stable and does what it needs to do. You can't do things in a vacuum. Reimbursement can't just add a charge without understanding that there might be ramifications in the billing function, and billing can't just, as you say, adjust off balances and not communicate when it's not the norm. So it really is important that all three understand they're all equally important into being successful as an organization. And if one fails, we all fail.
I agree. Alyssa, is it a good time now? Can we go ahead and ask our first polling question? I think that this might be a good time to do that. So the first polling question is, does your organization hold monthly combined meetings with revenue cycle, finance, and reimbursement?
I feel there should be music playing or something.
I know, right? Thanks for answering that chat question, Diane. So a whopping 72%, obviously that makes the most sense when you think about how you need to do any type of structure with the revenue cycle, finance, and reimbursement teams. And then also how else you hold people accountable and have ownership around that. So that makes perfect sense. And I'm glad to see that you guys are all doing that. Another area that we considered when we looked at how, how possibly organizations can bridge the gap, and if there was any lessons learned or anything like that around how we do that, was data and reporting. We felt that data and reporting is probably one of the most critical ways to be able to bridge that gap, because obviously the data usually speaks for itself. I think that when the four panelists talked about that, some of them had some really good examples of the types of data or the reporting differences they've had maybe in their organization that they've had now, as opposed to what they've had in others, or maybe in others they've seen better. So if any of you would like to share with the audience some of those data and reporting examples, this would be a great time to do that. We'd love to hear what you've seen work and maybe what you've seen that has not worked.
So at Memorial, what we have is we have Epic. And Epic, one of the things I love about Epic is it has a lot of dashboards and reporting natural for the system. We've always said an Epic can run, but you can't hide. The data is there for everyone to see, whether you like it or not, as long as you get the dashboard. So I think Epic does a really good job in providing a lot of information and KPIs. And they actually even have some, they call them, now I'm drawing a blank on this, pulse cards. So you can compare yourself to all Epic shops. You compare yourself to just large organizations, just pediatric facilities, just nursing homes. So you can see how you compare to Epic as a whole or as your peers. So it really does have a lot of information coming from an old mainframe system. Data was very scarce and hard to come by. on information even more so. I think Epic does a really good job giving us a lot of information that we can work on.
At Broward Health, we're not on Epic. And so we rely on a lot of dashboards that are put together internally so that we can track our KPIs and our metrics. And we do that both at the individual regional level, but also at the aggregate level. And we benchmark against each other because we don't have the ability to do that large scale benchmarking that you're referring to, Cheryl. And I did bring with me a scorecard that I can show you. And I thought that, I'm sorry?
That would be great.
Yeah, I'm going to see if I can figure out how to, I know I sent it to Misty. I don't know if she has the ability to pull it up real quick. But, one of the things about the scorecard while she's getting that pulled up for us is that it's actually put together by the finance team. And so the finance team is aware of all the KPIs that are around the revenue cycle and how it ties back in to the financial statements. And so, and it touches on things such as cash goals, clean claim rates, denials, first pass denials, just denial write-offs in general, AR aging. So I think that late charges, it really connects the dots at the facility level, at the corporate finance and accounting level, and then at the revenue cycle level. And at Broward Health, we have a revenue management department. And so they're also tied into, these KPIs. And so I think that when we have our monthly meeting, when we're all together in the room on the polling question that you just asked, this is often kind of the source document that we're looking at to determine if we're able to, to improve in a specific area. And we can certainly use these scorecards to see if there are any best demonstrated practices in our own system, and then adopt those at other facilities. So, and this scorecard right here that she has up on the screen right now is really a culmination of a lot of individual scorecards that are managed in the specific areas. And this is kind of the overarching, let's pull all of our KPI metrics together and then have a multidisciplinary team discuss and review so that we can find opportunities to move them forward.
How do you guys work through like the dependencies? Because you mentioned that this is kind of a scorecard that pulls, whether it's revenue cycle, finance, managed care, reimbursement. This is a wonderful, I think, a really nice depiction of how you have tried to bridge the gap between all of those areas. But when you sit down with your team, how do you talk about those drivers that are dependencies on each other? And sometimes, cash collections could relate to not necessarily revenue cycle. Let's say if the front end of an ambulatory operations area is owned by operations, but not by revenue cycle, like how do you guys work through those issues?
I think that, it's a team sport, as are so many things in healthcare. And, one of the things that, I've come to really respect at Broward Health is that, we will engage other areas that influence some of these metrics that may not directly have these as they're responsible for these KPIs. But to your point, they are in the operational side of the equation and they really do influence the success of these. And, case management's a perfect example, of that. And they have their own scorecard, but they're also at the table when we look at this one. So, I don't know if that really answers your question, but, from an ad hoc perspective, we do try to identify like who has influence versus who has direct impactability.
No, I think that's an excellent, this is an excellent tool, I think, that you guys have brought together to demonstrate all these areas and what they're all responsible for, and kind of holding each other accountable to some of these areas as well, I think is pretty crucial. I would say that's something in my experience. You can have the best revenue cycle, finance, reimbursement, managed care, they've got the correct contracts loaded. They've negotiated everything in a contract that operations can execute on. but sometimes operations, still there's things that fall through the cracks. And I think that having a good, in my opinion, also having a good CFO, and working with the operations areas, but also senior leaders like yourself and everybody on this panel building great relationships with operations, just to be able to kind of like always know what's going on and what's changing in their world, that will obviously have a downstream effect, obviously, to the financials.
Right, and providing visibility to them, because that's not always what they're looking at. And if you use late charges as an example, that's typically driven by some operational root cause. So I think having the opportunity, to involve our non-business partners in healthcare to help solve some of those root cause issues has really been helpful as well.
Very nice.
Candace, if I can add some things too on this from the
Please.
University of Miami standpoint, because we have our challenges too, because I consider us to be a unicorn, because University of Miami actually has 3 hospitals operating under a single license, and that includes an acute care hospital, a cancer center, and an eye hospital. So we can definitely develop metrics internally, but then having an appropriate benchmark externally is what we're finding the challenge with. So how do we benchmark to other academic institutions or cancer centers, because we have a unique patient mix and service mix, and also with our payer mix. So we do have those challenges with our internal data and as far as appropriate benchmark.
So I think I'd like to just to pause and ask the audience, and you guys can just like maybe raise your hand. I think trying to see where you can do this, but I'm pretty sure at some point, in the participants box, if you pop open your participants box, there's actually a place where it says raise hand. I just raised mine, and then you can lower your hand. But I'd like to ask everyone in the audience if they have some sort of similar tool like what Elisa showed, where it kind of brings all of those KPIs, whether it's a finance, revenue cycle, managed care, reimbursement, KPI, and brings them all together like that in one tool. How many of you, if you guys wouldn't mind raising your hands just so I can see as participants, have that? Okay, so far we have 3. Oh, there we go. About 10 raised hands. That's pretty good. How many would love Elisa to send that out to the group?
And Elisa, if you want me to, we can do that afterwards.
We'll just make sure we take anything that has Broward Health off of there, Elisa, but great
Absolutely.
tool. I think it's beautiful, and it definitely brings a lot of things together. So I love it. It shows a lot of great collaboration in your teams. And speaking of collaboration, that was one of the other things that this expert panels thought, that it's really important in your organization or any organization that you're a part of, to focus on, to be able to bridge the gap in these vital areas. So I think that's probably a good time just to ask maybe some of the other panel members, what best method have you found to bring these teams together and to collaborate in order to have better financial outcomes? If anyone else on any of the other panelists can kind of speak up and tell us what your experience has been.
Yeah, so this is Mike at Orlando Health again. This is one area where we've really intentionally engineered the collaboration amongst revenue cycle, managed care, and finance. Certainly monthly meetings around close so that we get the accounts receivable properly stated. There's obviously a collaborative effort around that. Certainly throughout the month, though, there are a variety of other meetings that take place, some that we've engineered specifically around making sure that contracts are being loaded appropriately. So you go back to the idea of control. We actually have our finance department load the contracts. We've recently converted it to Epic, so now we have a single platform. but then we get together with finance and managed care to make sure things are being loaded properly. And when there's questions or issues, what did you mean in this contract, or what did you mean with that term, or how are we supposed to load this reimbursement mechanism? Those are things that we have very open dialogue about and work through. And I would say a lot of this took place prior to the pandemic, but then with the way things kind of shut down, we had to pivot. So I don't want to get too far ahead of us here, but I'll tell you that, we've used a lot of technological resources to help engineer the ongoing collaboration between our different departments in this new world order.
Anyone else on the call that has any examples of how you guys have collaborated? I think what Mike spoke to definitely makes a ton of sense to me, especially with what he's done with his managed care department, embedding it in revenue cycle. I think it makes a lot of sense. But I am interested to hear if any of the other panelists, any lessons learned or success stories that you've had around collaboration in your areas.
Memorial is we've been doing our combined meetings for about 2 years now. We actually started with contracting, revenue cycle, and finance. But we over time realized, well, there's a whole other component with utilization review that we really need to include in that conversation. And we've now also included our professional billing, because we're having conversations that has a ripple effects across the whole continuum. So we also added HIM to the group. So it is truly now a great collaboration. And I think the knowledge sharing that we do on a monthly basis is beneficial for everyone, because I have a better feel now for what's going on in UR and what's going on in HIM and in PB, more so than before. Not that I didn't have conversations with them, but having a formalized agenda and talking through their specific issues, I think really does elevate the ability for you to work with the plans. And it all comes back to contracting and working with the plans, because as we all know, they all come up with different games to play in different arenas. And it's really helpful for both the CFO and for contracting to know just where they're doing their games lately, or in all areas at the same time, maybe.
Yeah, real quick, I'll say this too. I should have mentioned it earlier. When we combined revenue cycle under one enterprise, I didn't really articulate well enough that we put managed care, it's revenue cycle, we call it RMCM. So it's revenue management, managed care, care management. And the revenue management arm includes the HIM and coding department. It includes revenue integrity. It includes the physician and the hospital billing and collections offices. And then when we have the care management team, we also have a team of physician advisors that work with us on, the patient status determinations and the discharge dispositions. And what happens is our teams work together throughout the month to move patients through the continuum. So we'll get on collective calls with our physician advisors, with our care managers. We'll get into talking with the medical directors ourselves with these people. And it's all because we're operating under that same umbrella. And the other thing is, I'll tell you, yesterday, timely example, yesterday, Michelle brought all of her directors and above together to start now re-implementing what we had prior to the pandemic, which was a monthly roundtable with all the revenue cycle leaders around the table. And so we do that so that we all stay abreast of what everybody else is doing in the organization.
That's actually really good information. I have to tell you guys, I have not even thought about, we have utilization management committee here. We meet once a month, we review avoidable days, right? I mean, we look at those issues, but I've never considered putting UR or in those meetings with finance, reimbursement, and revenue cycle. And they do have a huge impact on downstream revenue and write-offs and denials and everything else. So that actually is a really good idea. I like that a lot. I think I'll just pause and again ask the audience. I'd like to see a show of hands for those in the audience who actually have already done what Cheryl and Mike is talking about, and that's bringing UR utilization review, utilization management, whatever you guys call it in your organization, to the table with some of these collaboration meetings with revenue cycle and finance and reimbursement. If you guys could raise your hands. I can't raise mine because I don't do that, but I like it. Okay, so this is not just new to me. We've got some people on the call who do this. So kudos to you guys all who do that. I mean, that's pretty innovative and slick, and honestly a wonderful way to bridge the gap to prevent some of those denials. And sometimes you just want utilization review and utilization management to be engaged right at the table with finance and revenue cycle. So great ideas, guys. I think I wanted to move because Mike, you were talking earlier about, you kind of brought up technology. I am interested in I guess I know you guys just started, I think recently this past year, you implemented Epic. Not that we need to have an Epic conversation, but I would like to know how your organization uses technology to bridge the gap, if there has been any new forms of technology that any of you have implemented in your organization. I think I'd like to have our audience hear about that.
Well, yeah, so you mentioned Epic, and I probably won't spend any time on that because it's a little outside of my scope. And frankly, I think it's still a little too new for us. We just did our last hospital conversion July 31st and still have a couple more physician groups to convert. So it's still not complete, and it's still new enough that, you know, we need a full year of data in there, frankly, before we can really begin to optimize it. But one of the things that we did, and I did allude to it earlier, was, you know, with the pandemic and with, you know, shifting to work from home and distance relationships, we've really extensively leaned into using Microsoft Teams. And so in these collaboration meetings that we have with finance, with patient accounting, with different areas, we set up channels, and there's tracking tools in there. You know, we embed documents in there. We also have process flows in there so that we can follow along and make sure that we're accomplishing the tasks that the collective group of people from different departments want to see get done. So, you know, I'm blessed that I didn't have to go learn how to use Teams extensively. We've got, you know, some very smart people on our team that kind of really figured out how to optimize it and, you know, again, build those tracking tools, those tickler systems, and it's all built into Teams so that at any point, anyone can go in there and look and see what's the status of this contract load or that contract review or whatever. And so, and again, we've replicated that in other areas of the organization as well, just using that technology because we're all communicating through it anyways. And that's just, you know, our organization chose Microsoft Teams for whatever other reasons, but we're using the technology that's available.
It's definitely a great way to bring the teams together and collaborate. Alyssa, I think this is a good time for polling question number 2. So number 2 says, have you brought in new forms of technology to bridge the gap or improve communication in these areas? So just remember, we're trying to think about technology of how we're bringing, bridging the gap with revenue cycle, finance, and reimbursement. So if there's anything, even if you put a business intelligence platform to help visualize what your all that data coming into your EMR. Even if you've done that to bring it all together, that's a new form of technology. Or even what Mike said, if you guys implemented a way to be able to bring these teams together through Microsoft Teams, I think that's a good way to think about new technology and tools, because one of our areas of bridging the gap is also collaboration and communication.
Guess while people are doing the survey or the poll, maybe I can add some things from the University of Miami, what we've done from a reimbursement standpoint. So obviously we want to make that shift of where we're spending, instead of spending 80% of our time doing processes and then 20% of our time doing analytics, we want to flip that, right? So we're 80% analytics, 20% process. So we've implemented a couple of technology to automate a lot of processes with the AR valuation. We love spreadsheets. Spreadsheets are great. They take a lot of time and they're very limited, right? So we've implemented a tool. We're still going through the the parallels to make sure that we're still comfortable with it. And then from a government reporting standpoint, again, another spreadsheet world where we're implementing electronic work paper sets so we can take advantage of the ability to upload data, or then it's already formatted, sorted for us, and then we can do the analytics and the what ifs to see how that affects us from a reimbursement standpoint.
Thank you, Robert. I also believe I love doing AR valuations. I think that they are something that must be done. I personally I try to do them every year, but it gets to be a little bit overwhelming, but especially before audit, I think that's, a great time to go through and look at it. So I agree with you. I think that's a great idea, and how you modify your process to include that. So the poll results basically just showed that, 65% of us have brought in new forms of technology to bridge the gap, and 16% haven't, and 19% aren't too sure. So pretty good response rate there. Bill has asked me to ask a question for our business partners. It says, for the business partner folks, a lot of our solutions will hopefully positively impact the hospital's bottom line. Do the panelists, so I think this is a question for the panelists, do you recommend that we include reimbursement and finance more in our presentations, or at least familiarize them with the work we're doing after we begin an engagement? So I think we're talking about our business partners who possibly are engaging our providers. And I think what they're first asking is, number one, should we include some presentations for the finance and reimbursement areas? And then for what the engagements that they're involved in, should we help the finance and reimbursement team bringing them together? So maybe we have a lot of business partners that focus on rev cycle, and I think what they're trying to ask is, when they bring revenue cycle to the table in our organization, should they be engaging finance and reimbursement? I will tell you that I say yes, 100%, always and forever. Again, I think that's how you bridge the gap between all of those areas. Revenue cycle, revenue cycle has its process and steps in the process to be able to get to their outcomes. Finance has theirs, reimbursement has theirs, but collectively, we all own the financial outcome. So I have always been a huge advocate of, whenever there is, whenever I brought a business partner in to do even an AR valuation, you're going to not just have finance at the table. You're going to bring revenue cycle in, you're going to bring managed care in, you're going to bring reimbursement in, because all of that information that comes out is really important to all of those key stakeholders. And if any of the panelists want to give their opinions as well, that would be great.
Absolutely, are part and parcel of what we do.
Yeah.
It kind of leads into the next question here too, Candace.
Yeah, so I wasn't going to talk about reimbursement since you covered that, Robert. I think what I was going to move into is, our world has shifted a lot, I would say, over the last 4 or 5 years, heavily into the value-based payment models. We would like to know, or at least I would like to know from the panelists, like, how do they see these value-based payment models, how the change in how we're being reimbursed and how we're being paid, and what these payers are actually asking us to do, whether you're upside or at risk. How have those payment models actually changed on how we do try to bridge the gap between all these areas?
So I'll jump in here again. This is Mike. So we've been on a value-based journey at Orlando Health for probably 7-8 years, and probably more mature than most, certainly, hospital systems, not just in Florida, but in the southeastern U.S. We make that claim in part because we just luckily bought the highest performing primary care group in town about 7-8 years ago, and that enables you to generate a lot of results. But I will tell you that we've intentionally aligned our population health and value-based contracting with our overall fee-for-service contracting strategies. We see them as sort of complementary pieces where our performance in value-based contracting gives us some negotiating leverage. But it also informs how we price things in negotiations. It informs how we run our rev cycle operations, because we're now sensitive to the coding specificity that's going out in our claims that ends up attributing a risk score to the cost factors that we're being measured on. So all these things are interwoven together, and it's really essential. And that's part of the reason why we're so thrilled to have gone full board Epic across the entire enterprise, is that now we have the ability to capture the right coding specificity, to capture the care gap closures, and to optimize our value-based contracts in a way that we never could before with 7 or 8 different disparate systems. So I think value-based contracting is still a small portion of our portfolio, relatively speaking. We're a $4.5 billion organization that probably makes, $20 million a year, I should say, not thousand, $20 million a year on value-based. So it's a tiny sliver, but it does inform a lot of the process and the way we want to strategize.
Yep, I agree. Do any of the other panelists have any, I know especially with these new types of payment models, it does sometimes, it changes the way that we look at our contractuals, it changes our revenue recognition, whether we're at risk. I mean, it definitely becomes, especially for your area, Mike, in my opinion, a lot of that managed care negotiation of those contracts. And that has to be a huge, it's a huge lift, in my opinion, of how we actually communicate that back to our reimbursement and finance teams. I would like to go ahead, Elisa, and ask polling question number 3 to the audience. So this is just something that I think is interesting, because I do know that there are organizations that have managed care, especially for those upside or at-risk contracts, for those value-based contracts. The managed care negotiations is actually, for those managed care contracts, is owned in the value-based operations area. But then some of them also keep it on the other side with the health system and in their managed care department. So does your value-based operations team have a separate structure to negotiate managed care contracts? We would like to know.
While we're pausing, I would think my strategic officer would push back on you, Mike. I think he feels that we have a very mature product out there. I can't argue that because I'm not the expert. But what I have seen is we had a primary care center that mostly was taking care of our uninsured population. And we have transitioned that into more of a value-based, taking advantage of ACA programs and things like that, and grown that program so that most of the patients coming through those areas now are insured patients, not uninsured patients. So I've seen the change, but I've also seen my radiology department got very excited until they realized that no, primary care isn't going to send all their chest x-rays to you. They're still sending them to the freestanding center because they want to make money there. So yeah, I think it gives you additional insight of what your future is going to be in your hospitals, so you can plan more accordingly, because we will see an erosion of hospital business. And I think if you're in value-based now, you get a better sense for what that timetable will be in your community and help drive that a little bit too.
I agree wholeheartedly with that, Cheryl. And I think that that's a really nice big picture holistic way to look at, value-based and how those payment models will actually impact us in healthcare delivery in itself. So the poll results actually was kind of split pretty evenly between, yes, they do have some of their value-based managed care negotiations in their value-based operations area. No, they don't. It still lives in revenue cycle, and the rest of the audience wasn't sure. So just to kind of close this out, based on what what's going on in the world today with the pandemic, I would like to ask this audience, or at least the panelists right now, has the pandemic? I know, Mike, you talked about Microsoft Teams being a great tool to be able to collaborate and bring your teams together with that form of new technology. I think I would just like to ask you guys if there's other complexities that the pandemic has added to everything that you guys have talked about in your organizations on how you've done so well at bridging the gap between reimbursement, finance, and revenue cycle. Has the pandemic added any complexities to your processes?
Yes.
It's not a rhetorical question.
If I see one more change in a modifier rule over the past 18 months, I think I'm going to spin like a top.
Yeah.
At Memorial, we say if you haven't billed a COVID claim 3 times, you haven't billed it correctly. We literally started copying all of the web pages, because you would dial in the next day and something that was there yesterday isn't there today, and you would swear. So we started that early on, copying all of that information, because our biggest concern is 5 years from now, some third party is going to come in and audit and say, oh, you didn't do this correctly. And if I don't have that piece of paper that I copied, I have nothing to support that. So hopefully I'll win the lottery between now and 5 years from now when these audits occur, so I don't have to be around for them, but they are coming. And the billing rules alone, I've been in healthcare for a very long time, and I have never seen so many changes in billing rules in the course of the past 18 months. I mean, if we open up one more surge unit where I have to put special codes on a claim to then close it, to then open it, to then close it, to then open it, and the codes go on and off and on and off. It's just been a whirlwind just trying to keep on top of the billing.
Well, and I'll tell you now, take all those changes that basically revenue cycle had to pivot on, right? Every time that legislation changed the guidance. I think take that and then bring it to your annual year-end audit, and then watch your auditors try to make sense of everything that happened in the financials as a result of how revenue cycle had to pivot. I don't know about anybody else on this call, but it felt like, it took us longer to get through our year-end audit, just because the auditors were having to figure out like what guidance to pay attention to in the quarter that they were looking at. So that was, that definitely added complexities to, I think, bridging the gap between these crucial areas. I'm just looking at the chat box for a second, just to make sure I haven't missed anything. Chuck Wood is asking everyone, Mike, does OH still have any, which is Orlando Health, guys, full risk or near full risk contracts like Disney? What is the experience, and does this shift to what does this shift to a cost-based approach?
Yeah, I was typing a response. I guess I typed it directly back to Chuck and didn't realize he had it out there to everyone. But I'll say this, I mean, yeah, we've got downside risk and a lot of different models depending on who the payer is, whether it's an employer directly like Disney, or even, the commercial and Medicare Advantage plans. And, our approach is one that, again, it's very primary care centric. We scorecard our physicians, we track cost and quality and utilization metrics, and it's all very transparent. So peer pressure and overall, performance of the entire ACO or the CIN really drives a continuous process improvement, continuous positive outcomes. I think at some point, the more we mature on the pathway, if we were to say start our own health plan or something like that, I think that might be a cause for a different type of operational and financial paradigm. But as it is today, we're still sort of living in a fee-for-service world, but succeeding in value-based because we're more efficient than the rest of the market, frankly.
Yeah. And just, Cheryl, just to give you a little bit of a feel good, Natalie and Pauline both agree with you about the constant billing rule changes and how frustrating it's been. And Natalie has done a pretty good job, it seems like, with getting some claims paid, because she looks like she did the same thing. She copied a lot of the payers' pages on how they were going to pay specifically for telehealth or telephonic claims. So that was interesting. And Jono, thank you so much. He says it's been very useful and educational. Loved hearing the great perspectives from all the presenters. So thank you, Jono. I appreciate that. At this time, I just wanted to pause and ask if there are any other questions from the audience, or any comments or anything else you'd like to see in the future of how we could improve on this presentation, or what you guys would like to see. Thanks, Greg. He also said he completely agreed. Thanks for the insight and knowledge. I think panels are my favorite at HFMA. You know, I love listening to all the different perspectives and what people have done, or to be successful, or even learned a lesson. Or if I have to sit through an education session, give me some sort of takeaway. I mean, that's obviously why we're all here today. Is Robert Howie? Oh, Robert, are you wearing shorts or pants?
I'm not.
Inquiring minds want to know.
I'm not going to answer that question. Who asked that question, by the way?
Bill? I don't know his
Bill,
last name.
Bill Icos, yeah.
Bill
I had a
Icos.
feeling it'd be Bill. I knew it'd
Of
be.
course, Bill.
No. I dress like this all the time at home.
No response, huh?
Natalie says it takes a village for sure. And Stephen Bauer said it's hard to operate and present, especially as a panel when remote, but well done today. So great job, guys.
Yes, we all agree. Thank you guys so much. Just want to, for those of you that are not an HFMA member, we do have a few on. An all-inclusive one price membership offers the most relevant resources for healthcare finance professionals to meet today's challenges. You can get more information on becoming a member at hfma.org. Next up is going to be the Fun Committee Bingo, virtual bingo. This is going to start at 11:45 and go until 12:30. Then we have our 1 o'clock session coming up, which is federal legislative update. And that's also going to be a panel. I think it's going to be very interesting. I've seen some of the questions and I'm looking forward to that. Last but not least, going back to the bingo game, there's a $200 gift card to the winner. It is, I believe, an Amazon gift card. I know I would love to have that. So hopefully you guys will join us. And if you don't have, you should have the link on your calendar. If you don't, it should be here in the chat box. Alyssa, if you make sure that's on there.
He's got it.
And I think that'll do it. You guys, thank you so much. And we look forward to hearing more, hopefully more of this. Maybe we can have updates at our May meeting in St. Petersburg. So have a great quick lunch and we'll see you soon.
Thank
Thanks,
you.
guys.
Thanks all.
Thank you.
Buddy.
Okay, thank you.